All right. Hi, everyone, and welcome to today's program, The Future of Lymphoma Therapy, Expert Perspectives on Breakthroughs and New Combinations, which we've been hearing a lot about. So what is the discussion focused on? We're talking about the two most common subtypes of non-Hodgkin lymphoma, DLBCL, or diffuse large B-cell lymphoma, and follicular lymphoma. Again, two very different spaces. So why now? Well, we just had a recent meeting of the minds from all over the world called ASH, the American Society of Hematology. And what that basically means is doctors and researchers are presenting the latest updates on treatments and potential treatments with the most promise. So our goal is that you walk away today as patients, as caregivers and partners with better understanding of how to approach your own decision-making with your medical team, specifically on how to understand what the options are and balancing effective treatment and of course, quality of life. And I know there's going to be a great conversation ahead. So just a little bit of housekeeping first. An introduction. My name is Stephanie Chuang. I myself am a non-Hodgkin lymphoma survivor, and that was diffuse large B-cell, and that was about 7-8 years ago. So I'm very thankful that I've been no evidence of disease since. But as we know, there's just so much that goes into trying to navigate life after a diagnosis. And so that's why, I started the patient story. We build community through content and education with the mission to help people navigate that life before, at, and after diagnosis. And most importantly, to do it in human terms, not medical jargon. We do this through in-depth patient stories, educational discussions like today's. And we do this also in collaboration with partners like the Leukemia and Lymphoma Society. I want to thank the LLS for its partnership in this. If you don't know already, the LLS is great with lots of resources. They offer free ones like their information resource specialists and the Clinical Trial Support Center, which is staffed to provide one-on-one support for free in different areas for the blood cancer community. So thanks to the LLS for its collaboration. Before our speakers come on, we also want to thank our sponsors today, Genmab and AbbVie, for their support, which helps us to host more of these programs and for free to our audience. I do want to say that the patient story retains full editorial control over all of this content as always. And while we hope that this is helpful, keep in mind this is not a substitute for medical advice. Still consult with your own team about your decisions. Lastly, we always want to hear from you. We know it takes a lot to make it here and we want to do better. So a survey is going to pop up at the end of this discussion. Please let us know what we could do better, what you want more of, and that's going to come on after this program ends. All right, and today we have an incredible panel of experts to discuss these latest advancements in the field. The intros could be extremely long, so we're doing just a few bullet points, but go check them out after. First, Dr. Tycel Phillips, hematologist-oncologist from the City of Hope National Medical Center, that's in Southern California. He's an associate professor in the Department of Hematology and focused on treating patients with lymphomas, both Hodgkin and non-Hodgkin. What really caught my eye more was the stated personal mission for Dr. Phillips, who lost his grandmother to pancreatic cancer and his mother to breast cancer, and that happened when he was studying to be a doctor. So I'm sure that really informs the way that Dr. Phillips practices now as a doctor. And then Dr. Andy Evans is a physician scientist and clinical expert in lymphoid malignancies at the Rutgers Cancer Institute in New Jersey. He serves as Associate Director for Clinical Services at the Institute of New Jersey, the Associate Vice Chancellor for Clinical Innovation and Data Analytics at Rutgers Biomedical and Health Sciences. And I'm trying to catch my breath. There's so many. Over the past 2 decades, he's been the principal investigator of, it said, more than 80 cancer clinical trials from phase 1 through phase 3 studies. And in terms of personal inspiration, I'm told his parents were both pharmacists in the medical field, and he wanted to make a difference too. And that led to this field. So thank you both for being here today. Our audience is cancer patients, the people around them. I want to set the stage that the two of you are clearly dedicated to not just the patients you see in your own clinic, but to the research that's happening in lymphoma. And you go above and beyond outside the clinic walls. So thank you so much for that, especially as a former diffuse large B-cell lymphoma patient, a DLBCL patient. I just want to set the stage that today we're actually covering 2 types of non-Hodgkin lymphoma. One is the most common aggressive form, which is diffuse large B-cell lymphoma, and the other is slow-growing or indolent, and the most common form of that, follicular lymphoma. And so, we often see a lot of research in these areas. So without further ado, doctors, let's go into DLBCL first. So the goal for today is to translate for our audience what matters to them. For DLBCL, can you set the stage first, Dr. Evans, on what's been the standard of care, for frontline therapy for DLBCL, and sort of set into context what is happening now with frontline therapy options after we have the POLARIX trial, where the FDA approved some very new, for the first time in decades, a new option for patients.
Sure. Well, first of all, Stephanie, thank you so much for the invitation. Great to be here with friend and colleague, Dr. Phillips. It's really cold here in New Jersey in the 20s. I wish I was with Dr. Phillips right now in California, but that's okay. Maybe he'll invite me sometime. But no, it's evolved, and you just said it. We were really had this regimen, and we use a lot of abbreviations, as you know yourself, something called R-CHOP, rituximab and CHOP. Those four latter letters, chemotherapy, had been the standard of care really for more than 15 years after rituximab broke through around 2005. And it wasn't for lack of trying. A multitude of randomized phase 3 studies over the ensuing 15 years, either added to or after different iterations to try to knock R-CHOP off the top of the hill. And finally, one at least had some benefit. We can talk more about that. And there was some extra data at the meeting presented. And you mentioned polatuzumab vedotin. Sometimes the short is POLA. And it replaced the O, Oncovin, in CHOP. So it didn't add, it replaced in a head-to-head study. And it garnered, to your point, FDA approval after a phase 3 randomized trial. That acronym for the trial was called POLARIX. And so, again, sorry to belabor on all the acronyms, but it's POLA-R-CHP, CHP. And I would say it's broken through. Now, is it used in all patients? I think that's open for discussion. It's FDA approved for all patients with higher risk. You have to have a certain clinical risk score called the IPI, 2 and above. And if you have that, it is FDA approved for your disease. And so it's definitely a breakthrough. There's no way around it.
Thank you for bringing up the impact to people and the considerations you have. If we could shift, and maybe the two of you could also speak throughout this, sort of the overall impact that POLA has had, I don't know, on the research and what's possible. But on that note, we're coming out of ASH, right, Dr. Phillips, this big conference. And so for you, what excited you the most about the ongoing studies in the first line, for first line treatments, specifically with R-CHOP and novel treatments?
Yeah, I mean, surprisingly, it was a whole section dedicated to R-CHOP, plus X in that situation. So I think the POLARIX study invigorated, I would say, the field to actually explore more options to improve the frontline setting. Because I think after so many negative studies, we had hit a point where there was very little interest in exploring a way to sort of improve R-CHOP. So, but in this, ASH meeting, so there was a few studies. So there was venetoclax added to POLA R-CHP for patients with aggressive B-cell features. And this was presented by Dr. Diefenbach. And so this study looked at venetoclax at a dose of 800 milligrams given for 5 days, which indicated, across the board, still very short follow-up, all of these, a very high response rate, even in those with triple and double hit lymphoma, albeit only 7 patients. But again, in this situation, a way to sort of move the needle. Some drawbacks, obviously, from this one was higher rates of neutropenia and some grade 5 events. And so, if that were to move forward, there may be some dose reductions to the venetoclax dose because they went up to 800 milligrams. And the question is that really necessary? And so moving in sort of on that theme of just adding a small molecule to a chemotherapy backbone, there was a study looking at parsaclisib, which is a PI3 kinase delta inhibitor in patients with R-CHOP, which was presented by Tycel Wang from Mayo Clinic. Surprisingly, this showed a very high overall response rate overall for the patients enrolled. It's still a small study. It did not appear to be very subtype specific, so a little bit agnostic. But as Dr. Nevis can tell you, the delta inhibitors have become a dirty word in our industry. And so how that moves forward will be very interesting, considering that for the most part, outside of CLL, these drugs have pretty much been killed off by the FDA. Additionally, there was a new CELMoD golcadomide in patients, golcadomide plus R-CHOP in patients with large cell lymphoma. This was presented by Dr. Jason Weston from MD Anderson. Again, this compared to lenalidomide, which is sort of built off of. This one supposedly keeps cereblon in a more closed configuration, so more inhibition of Ikaros and Aliosin, so more T-cell activity than what we saw with lenalidomide. And this also had a very encouraging high overall response rate, but I think we can all agree we can't really hang our hats on phase 2 studies anymore. But this one will move forward into a randomized phase 3 trial to try to see if this can improve upon the R-CHOP backbone. Dr. Fauci presented a study with epcoritamab and R-CHOP. So epcoritamab being a bispecific antibody. And again, in this situation, very high overall response rate. And again, in this patient population, which we all suspect bispecifics will likely move forward into this space, there will be a phase 3 study looking at epcoritamab in this patient population. And lastly, we had the coalition study, which looked at glofitamab and R-CHOP, or glofitamab and polar R-CHP, which again, sort of the theme, very high response rate in the phase 2 studies, very impressive complete response rates and high short-term duration of response, but again, more follow-up. And as Dr. Evans can attest to, there's a third bispecific, the Olympia study, looking at odronextamab in this patient population. So it's going to be a very, very difficult sort of next couple of years teasing out what is the new standard of care in frontline large cell lymphoma if any of these phase 3 trials are positive. And there are several ones that we didn't even mention that will likely read out in that time frame. So interesting time thing, but again, a bit confusion based on the backbone that's being used, R-CHOP, polar R-CHP, and sort of the partner drug.
And so Dr. Phillips, thank you so much for going over all of that. And to your point, it's funny. You could characterize that as difficult. It's confusing because there's so many options now in a space that you're looking at. So Dr. Evans, to contextualize this for the people watching this, right? I think obviously top of mind is, to Dr. Phillips' point, we're in trial and studies for a lot of these, TBD on whether they get approved. But it's like, how long until people could potentially see some of these options? And I guess that's getting out a little bit ahead. Maybe even bigger than that is, let's say they all do get approved at some point. How would you make a decision for individual patients on recommendations for which way to go?
Yeah, and it's a lot to digest. And Dr. Phillips did a great job. And as he alluded to, tip of the iceberg. But it's confusing, and we say it's a competitive landscape. But through the lens of the patient, I think it's fantastic because it means we have a certain standard, we have a certain cure rate, we're trying to do better. And so at the end of the day, whatever gets approved will be great for patients. And then it'll be up to the providers together with patients to say, well, what's best for them. And we always desire what's called biomarkers to try to predict personalized therapy. Can we actually find a treatment or a regimen for particular patients? We're certainly not there yet. But that's hopefully along with, in parallel or at worst in sequence, not just that we have a regimen approved for a large general patient population, but can we actually start to figure out who it works in? But to your point, it really is always, of course, how effective is it? Meaning not just that initial response, but obviously we want it to be stable, stay in remission. Of course, number 2, or 1A, 1B, is how's it tolerated? And if it is as good or better tolerated, fantastic. If there's some different or unique toxicities, well, is it balanced out by the efficacy? And then maybe 3 or 1C, we think about cost of care. We want to make sure it can be affordable for patients. And at the end of the day, whatever is approved down the road that builds upon R-CHOP and polar R-CHP, it's all good news. And we'll just have to kind of patient by patient make those smart, informed, personalized decisions.
Yeah, I think ASH in 2020 2026 and 2027 will be quite interesting.
There's going to be a lot. My bet is most won't, like, you know how it goes, Tycel, most won't break through,
Sure.
but maybe I'm wrong. I mean, I think, as you mentioned, we were at that one ad board, probably the bispecifics had the best chance.
No.
Um, Thank you so much, Dr. Evans. Both you and Dr. Phillips, have laid this out very beautifully, I think, for people to understand. Maybe another way of asking would be then for all the options that Dr. Phillips, you just talked about, and Dr. Evans, you just said bispecifics look like they might rise to the top here. Can you share more about why that is? And anything that, you talked about more personalized medicine. We're certainly not there yet with biomarkers, but it's a conversation that is very hot, right, for patient advocates as well. So maybe the second part of the question would be for the two of you, what guidance you have for patients to be asking their doctors about, well, for me, what can I be asking you about for these different options? We can start with Dr. Phillips.
Yeah, I mean, with the bispecifics, I think part of the sort of belief in how they will be upwardly mobile is that they're really built off the backbones of these monoclonal antibodies, which have revolutionized how we treat patients with lymphoma. As Dr. Evans mentioned, I mean, the major improvement was the addition of rituximab to a chemo backbone in CHOP. And so ideally, if we look at, glofitamab, epcoritamab, odronextamab, mosunetuzumab, a lot of these, they're still built off that same paradigm. And in this sense, we're also encouraging the patient's own immune system to take more part in trying to fight off these cancers with the addition of chemotherapy drugs that are not necessarily immunotoxic. So in that sense, the combinability and the safety of these medications, especially when the patients get a few cycles of chemo first, really support their addition to the frontline regimen. Because again, it is that balance. If you have all these different options, I mean, we're going to start going into the weeds and figure out are there anything that separate these sort of regimens we have. And one thing may just be the safety and tolerability and the convenience of giving these to patients. I mean, is it more convenient to come in for an injection or an infusion every couple of weeks or having to take a pill for a certain number of days? We already know that compliance with oral medications is not great. And a lot of the efficacy, while you may get that sort of surveillance and pharmacovigilance on clinical trials because you're having to bring in diaries, well, outside of a clinical trial setting, that doesn't happen. And so patients will quite frequently not be as adherent to these medications as they should be, and that may impact clinical outcomes. So again, echoing Dr. Evans, is an exciting time. And again, another part we also want to look at is, how they may impact certain subsets, as we were discussing with Polarix, is the issue of subtype specificity. But do we have other treatments that may be agnostic to subtype? Or if we start getting more of these molecular tests that will sort of chop patients up into certain subtypes, how do these treatments broadly apply across the board? Or do we need to play mix and match based on a person's genomic profile, which we're still a ways away from that, but I think that's a place where everybody is trying to get to, where, as you mentioned, it's more individualized for the patient versus, everybody walks in and gets the same thing, even though they're not the same.
So, yeah, Dr. Evans, would love to hear from you as well on this.
Dr. Phillips really summed it up great. I mean, I would just maybe piggyback a little bit and say clinical trials, because it can be overwhelming, or this medication, that medication. There's not a better or best clinical trial. To me, they're all good options. And obviously, that is one thing I would ask your doctor is there, what's currently FDA approved for my condition, number one. And then number two, I think it's absolutely fair to say, are there any new treatments? And not meaning for newly diagnosed first in human, that's for newly diagnosed. These are usually very mature clinical trials where you're frankly taking whatever the standard is, R-CHOP or POLA-R-CHP, and trying to do better on that. Of course, also looking at safety. So I think those are really the couple quick things to ask about a clinical trial would be really important.
And thank you both for calling out the differences. Again, there's the clinical trials where we're studying all these things and these possibilities, and then there's the actually approved, right, options. And so we kind of, the patient story, we kind of set this conversation up a little bit backwards in terms of clinical trials, in that, much of it is done for the relapse refractory, first, and then it works its way up usually to earlier lines of therapy, because we're going to talk about bispecifics also for relapse refractory patients. Dr. Evans, following, all of these different, I know you talked about bispecifics rising to the top. Is there anything else in terms of long-term benefits, long-term risks for what we understand so far when it comes to everything that was studied at ASH or presented at ASH, I should say?
Sure, and that's we said 1A, 1B, 1C, probably 1D or number four, whichever way you want to number it, is what about after treatment, so-called recovery or survivorship or wellness, whichever word that is. And very important. But yes, we want to cure. Yes, we want to cure with as minimum amount of side effects and hopefully fairly cost-effective treatment. But do so there are not those late effects. And I would submit that really remains to be determined. The hope is, since these agents, for the most part, are not classical cytotoxic chemotherapy or radiation, the hope and expectation is they're going to have less late effects, whether it's cardiac or infections or pulmonary. But at the same time, of course, we can't assume anything. And it needs to be studied. And my hope is that whether through the pharmaceutical companies or through academic institutions like Dr. Phillips and ours, that'll be bolted on in some form or fashion to these studies to follow for late effects, whether it's 5 years later, 10 years later, because we certainly don't want to cause harm down the road.
Thank you. Yeah, Dr. Phillips, anything to add there?
No, I think Dr. Evans summed it up appropriately. I mean, again, when you have options, then you could be a little bit more stringent about uh, what's the best thing moving forward. So that's what he mentioned in the beginning. The more options, the better it is for our patients.
But then that is, I'm sure, Tycel, you guys have survivorship expertise there, do you not, at City of Hope?
Yes, there is a survivorship clinic.
And I think that's just something also. Now it's after treatment, Stephanie, it's not during. But um, I think in the past, I wouldn't say we minimized it. I would say maybe we didn't appreciate or have the science associated with survivorship or wellness after treatment. So that's also a valid question for your oncologist is, can we talk more about my individualized survivorship or wellness, whether it's 2 years, 5 years later? And at least in most academic centers, and I think even in some non-academic centers, there is that survivorship expertise, whether it's in some sites led by nurse practitioners or physician led. It's really all good as we get into that important part, the rest of life.
Yes, life after chemo.
Yes, I can't tell you both how much I personally really appreciate that you brought that up, that piece. And I love how survivorship is becoming much more of a focal point. I went through hundreds of hours of chemo. I actually didn't undergo R-CHOP. I had dose adjusted R-EPOCH. This was 7 years ago, and just the thought of being able to have a focus on survivorship and what are the things that I need to look out for just because my body went through this is so wonderful as a trend.
How long ago?
I went through this in 2017.
Wow. Congratulations. You
Thank you.
Look great, and hopefully you're doing well, and I'm sure, yeah, but it's something to bring up. And I don't want to make it seem like it's an epidemic or malady of side effects, late effects. They're slight, they're subtle, but they are real. And we're still learning a lot about it. We've learned a lot from Hodgkin lymphoma. That was one of the first curable cancers in man that we learned in the 1970s. So we've learned a little bit from that. But a lot of the medications, in particular anthracyclines, the vinca alkaloids, the alkylators they're called, whether dacarbazine or Cytoxan, are very similar. And so they're probably more similar than not. And frankly, regardless of age, because, and we also, one other important pin to put in this point is sometimes we hear late effects and we think, well, that's 20, 30 years down the road. What we're learning, at least in Hodgkin's, and it's probably true in large cell if we take a close look, is really within a few years. And for sure, by 5 and 10 years after treatment, we're already seeing some of these late effects. And so, yeah, really important to get that understanding from your local oncologist or survivorship expert.
Yeah, I think to your point, especially with the anthracycline, I mean, I think a lot of times we didn't look. And when you look, you see a lot of cardiac effects, even within a year after completion of treatment.
You do. Now, it's always tough. Tycel, it's kind of like, what do you do about it? But I think it's at a minimum, it's kind of a control your risk factors, hypertension, cholesterol. It certainly can't hurt. It's only going to do the body good.
Yeah. And I think a lot of sites have cardiologists now that have taken quite an interest in, oncology related events. And so there are a lot of processes and steps, cardiac rehab per se, that have helped ejection fractions for a lot of patients. So
And there's more funding. I'm working with a cardiologist. She was at Tufts Medical Center. She's now going to Beth Israel in Boston. She's a cardio-oncologist, to your point, Tycel, and she just got a big grant funded to look at some cardioprotective agents early on. So thankfully, hopefully there'll be kind of some resources, because it's always hard, Stephanie, whenever we talk about doing research, as you can imagine, you need money, you need funding. And there tends to be a lot more from the pharmaceutical companies, understandably, with the medications. And survivorship, there aren't as many companies there. And so we rely on the government, through the National Institute of Health, or NCI, philanthropy. And there might be some other ways to do that, but it's just such an important part to cancer care.
100%. Yes, let's get more funding for that, because that is so impactful for people. I heard cardiac. Are there any other late term, effects that people should be thinking about if they've undergone, any of these, especially like the chemoimmunotherapy, and actually it's sort of an addendum to that question, based on what you all are talking about from the R-CHOP plus X from ASH. Anything else to call out specific? I know we had some conversation about side effects in general, because I think for a lot of people, they might think, oh, well, you're adding something here, so does that mean I'm going to go through more?
yeah, I think it depends on the drug. I mean, for your first question, obviously, the other thing we think about is with the various agents, there is always that small but risk of, secondary cancers that come from these chemotherapy drugs. And whether you receive radiation or not, that's also a very important concern. As I think we've learned long term that some of these radiation risk factors don't plateau, and they sort of age with the patient. Uh, and so those are all things to keep in consideration with some of these other drugs. Thankfully, I think, even with like and Christine, which is a microtubule inhibitor, the biggest thing is the neuropathy. And as the risk with that is that sometimes, with the nerve damage, it's always unpredictable. And you may not actually get, resolution of those symptoms. So there's always that concern and modulation and try to preempt that from happening. And so with some of these newer drugs, obviously, as we mentioned, it's depending on the class of drugs, they all have some unique side effect profile. Obviously, in the frontline setting, they're given for a more limited fashion, which would hopefully prevent some of the side effects that we see in the relapse refractory setting, especially for some of these drugs that are given until intolerance or progression, which is always a concern. But ideally, looking at delta inhibitors, it's generally always, you worry about liver irritation in some situations, diarrhea, and infection risk. But again, that was with the relapse refractory setting and indefinite use. Golcadomide, which is like a lenalidomide analog, obviously, reproductive risk is always a concern with that class. And so if you're a young woman, that's always a concern and handling that medication. And then it can cause some neutropenia, which may increase your infection risk when given with chemotherapy. And then even with the bispecifics, obviously cytokine release syndrome is the biggest concern. And what I mentioned is sometimes, depending on when you give the chemo, you may mitigate a lot of the, higher grade cytokine release syndrome. So you can potentially, make that a bit easier to tolerate, less risky if you give a little chemotherapy to debulk the tumor and also maybe causally, blunt the immune response a bit in these situations. So ways around these things, but again, concerns to be had.
Thank you. Thank you. That was great. I'm cognizant of time. I'd love to shift over to, was there anything that we missed in terms of newly, like for frontline therapy? I know there's a lot to talk about, but
No,
I think we captured a good
we hit it.
summary.
Yeah.
Awesome. Love it. Okay. So let's move to relapse refractory DLBCL. First, the thing is, we've talked a lot about bispecifics already. So let's just go ahead and address that first, because we know are two, I believe, approved
Yes.
bispecifics for DLBCL. That's glofitamab and epcoritamab. So, and you both mentioned them already. Let's see here. Yeah. Can Dr. Evans, can you talk about the most recent sort of data? What's relevant to patients about the two of them and the differences?
Yeah, generally speaking, it really dovetails off of a lot of what we've already said. They're very active. There are side effects related to it, thankfully less than CAR T cell therapy, but similar to CAR T, meaning this entity called cytokine release, were almost like flu-like symptoms, and then some neurologic side effects as well. Thankfully, it's less common, but it can still happen, and so there certainly needs to be caution. But really, when we're meeting a patient who received frontline therapy, let's say they received R-CHOP or Alpolichip or dose-adjusted EPOC, and there's a relapse, yeah, the historic standard had been an autologous stem cell transplant. And that's really gone down, not away, but down with CAR T cell therapy, commercial CD19. And I know your question was about bispecific antibodies, but there are multitude of new CAR constructs because the current commercial CARs are CD19, but all different CARs and double CARs and even triple CARs trying to attach. And more often than not, that's the treatment of choice for many patients in the first time. Relapse is a word we would use, coming back, especially if it's within 12 months. And so, because the space, at least currently in diffuse large B cell for the bispecific antibodies, have been after that. Not that it would be wrong to do in lieu of CAR T, we just haven't seen as much of that data. And so, in some ways, that's where the bispecifics have tried to leapfrog and go to the frontline setting on that. But whether it's used in second line or third line, the bottom line is both of the medications you mentioned are very active. They're more similar than different, although there are some key differences. One standardly is given intravenous, one is given subcutaneous, one has a few more doses than another, but they're largely much more similar than they are different. You don't ever use standard before CAR, do you? I mean, and someone can take CAR, right?
That was a bridge.
Are you doing bispecifics as a bridge to CAR sometimes?
Only in patients whose disease is like rapidly progressing, and we need to just stabilize before we can get them to the CAR product. But I agree with you. CAR equals cure bispecifics. We guess, but we don't know for sure. So until we can be 100% certain, you'd be very hard pressed to really put a bispecific before CAR in the second line space.
Part of that, to Dr. Phillips' point, Stephanie, is time. CARs have a several year lead time. And to really say cure, 2 years in remission is a pretty good point. 5 years, you feel really good. And that's where we see CAR Ts. We saw some data at the meeting kind of settling out around the 30%, maybe 40% range. We're hopeful that we can say cure. We just don't have that lead time, so to speak, with bispecifics, although we'll see over the next couple of years where those land.
Right, right. So your point is that the CAR T came out first in research, and so there's more data, real world evidence about how they perform. And I know Dr. Phillips had talked about that earlier. And it's, we talk about it, clinical trial and the information that comes out of it. It's maybe a different population. So it is really nice to be able to see what happens.
I will say, except for CAR T has remained really reproducible in the real world space as it has in the clinical trials, which is not the same that we see with a lot of other drugs, where you typically see a decline in efficacy once you move out of the clinical trial space. That hasn't really happened with CAR T.
Yeah, I mean, it's a little different, but to Tycel's point, not like some medications, you bring it to the real world. And when we say real world, clinical trials are real world. It's a little bit of a lingo that we use. It's really like if Dr. Phillips and 3 or 4 other centers want to go back over the last 5 years in a retrospective fashion and look at our data, meaning all comers, not like you have to have these qualifications for a clinical trial. That's kind of what we mean by reproducing or real world, kind of going back at our local centers of how we treat every day, regardless of your kidney function, your age, et cetera. And he's exactly right. And just to really put an extra point on that is why CAR T and bispecifics, for that matter, is there's almost not an upper age limit. Where, as I mentioned, autologous stem cell transplant, you can understand up to the 70s, maybe 80, it gets a little tricky. And not to say it's a walk in the park in your 80s, but they're very manageable and doable. CAR T and bispecifics, I mean, in those older age groups.
Right. Again, more options. So actually, let's talk about that, since it's immunotherapy, and we have the CAR T that happened first in the research, and people were talking a lot about that. But bispecifics was kind of like the new topic. How would you? We didn't really talk about the mechanism, I guess, of bispecifics. Could you summarize, Dr. Evans, sort of just the mechanisms between CAR T cell therapy and bispecifics in a way patients can understand?
Sure. It can be confusing for sure. And I would frame them both under the rubric of immunotherapy. And whereas, and let me just for context, we talked about an autologous stem cell transplant, which is also a fancy word. It's not really like getting a new liver or kidney. That's called an allogeneic. An autologous transplant is really just one cycle of very high dose chemotherapy. So just blasting, hopefully the lymphoma way, but what about blasting your own cells? And so we know what's one of the most powerful anti-cancer agents are your own immune system, in particular your T cells, T as in Tom. And and we don't know why, but in some cancer patients, lymphoma patients, they're not doing what they're supposed to. And so what CAR T cell really is filtering out part of those immune cells, your T cells, and sending them to a company. And over about a 3 to 4, sometimes 5 week period, they're re-engineering it, really doing two things. They're actually transfecting an antibody. So you're kind of making a B cell to tell it where to go when you put it back in. And then in some ways, you kind of supercharge it or you activate it. So when you re-inject it, it's a one-time treatment several weeks later. It not only rapidly expands, but hopefully it goes this supercharged T cell with the CD19 attached to it wherever the lymphoma is in the body. So that's CAR T cells. What are bispecifics? Similar in concept in that it's the immune system, but it's off the shelf, not on one of my bookshelves, but in the pharmacy. And it's off the shelf treatment. It's really the way to think about it most simply as a double antibody. And so what are these double antibodies? It's a CD20, which interestingly is rituximab. So you would say, well, if rituximab in most patients stop working, why would this? Is because the second antibody is CD3. And so when it's off the shelf and injected, what it does is, yes, CD20 goes to where the lymphoma is, but the CD3 has T cells attached to it. So it delivers the patient's own endogenous or in vivo T cells to where the lymphoma is. And it's remarkable. I mean, I've had a multitude of patients, as I'm sure Dr. Phillips has, where CAR T is given, it doesn't work, and we don't honestly know why, but we're thrilled when it happens, and then you get bispecifics, and the lymphoma completely goes away. And this is someone who's already failed regular CD20, single antibody, CD19 CAR, and then just a different immunotherapy for one reason or another really is effective. And that's just another part of science we hope to understand is, again, which treatment works in which patient, whether CAR, whether bispecific, et cetera.
It's a lot of science to wrap up into this very abridged version. But I know the goal here is, okay, this is more targeted. Like I'm hearing a lot of, okay, it's engineered and then using your own system and then it's targeted with the goal being that we feel fewer side effects than like the blasting of the whole body with chemoimmunotherapy. So I guess Dr. Phillips, is that sort of how people can think about that?
I think the easiest way to sort of compare chemotherapy to some of these other treatments is, I go back to the military where chemo is basically like napalm. I mean, it's going to kill anything that is growing rapidly because that's what it's designed to do. It isn't specific for anything one way or the other. A lot of these targeted treatments, such as bispecifics and then obviously CAR T, are more so focused on directing your treatment toward the problem, which is in essence a malignant B cell. I mean, there is still some ambiguity because normal B cells will be impacted because, again, we're still targeting towards CD20. Hopefully in the future, we'll have some sort of cancer-specific marker that may even spare normal immune cells. But to this point, we're sparing a lot of other tissue because, again, it's just directed toward a malignant B cell, which chemotherapy just can't do. The closest we can get to that is with these antibody drug conjugates, which would deliver a toxic drug directly to the tumor. And then, the drug isn't active until it's internalized and then it can kill the tumor off. But even in that sense, you will get some spillage as the cancer cell sort of dies and opens up. That drug is also free to, kill other bystander tumors, but also any normal tissue that's in the area, which explains some of the side effects we see.
Thank you. I appreciate it. I love it when there's like real world sort of verbiage so people can understand it better. Thank you. Dr. Evans, to sort of wrap this part of it, it was mentioned earlier, cytokine release syndrome as one, sort of a very monitored side effect when it comes to immunotherapy. Can you talk about what does that look like in patients and the differences between what you've seen in the responses with CRS from CAR T versus bispecific?
The actual when it happens is very, very similar. It's just thankfully with bispecifics, usually less frequent and less severe, although not zero. And so you still have to have some caution. And we don't like to talk about it, but whenever we mention grade 5, that's a fatal side effect. And thankfully, it's very, very uncommon. But we want to keep that 0%, of course. And as long as there's the right training, the right medication on the shelves. And when I say the right training, by the way, it's not training of just the oncologists, doctors, and nurses and pharmacists. It's making sure your emergency room knows, your intensive care unit. You're really, like many things in life, preparing for the worst, just in case it happens. And so, for example, if we give bispecific antibody on a Friday, I had a patient actually on a Wednesday. I have clinic, and that night had a very high fever, had a little bit of a delayed cytokine release. And so he went to the emergency room. We have a protocol. They know what to look for. We had a conversation and we were able to mitigate it. And actually, the patient did not need to be admitted to the hospital. The fever quickly came down. He felt fine. So you really need that team sport activity as we're managing some of the side effects. And thankfully, almost always it is very manageable. But important to have that communication, collaboration across all specialties.
Yeah, thanks for calling that out. It's a huge topic too, right? On the logistics side for patients and considering what do I have access to? So Dr. Phillips, can you sort of paint that picture for those considerations when it comes to patients? Do I have to be monitored? Like how long do I have to be monitored for potential CRS after CAR T, after bispecifics, and how that can impact maybe the choices that they may have depending on where they live?
So, I mean, in essence, CAR T is a little different. I mean, we typically will think that the patient will be in and around the cancer center for about 30 days. And you also are required to have a caregiver with you. And so somebody with you almost 24/7. And so even in institutions where we can move them, patients outpatient for CAR T, that still requires you to be on the campus, still requires a caregiver, and then you're back and forth in, a quasi day hospital. And so that does require a bit more logistical hurdles to get over. But in some sense, CAR T is also akin to transplant centers. So a lot of these things are already in place, at least as far as the inpatient portion, because again, instead of admitting somebody for high dose chemotherapy and then a stem cell rescue, you're basically giving them CAR T instead. And again, with the whole inpatient stay monitoring and sort of the same situation of a very close follow-up. Now, while you're in the hospital, they'll be monitoring you for neurological changes, and vitals will be taken to monitor for any signs, symptoms of cytokine release syndrome. So, again, these are things done very closely. Bispecifics, on the other hand, as Dr. Evans has already sort of eloquently elucidated, can be given in a community setting. The only real thing you need to have, as you say, education for the patient and education for your staff about what may happen if something bad things happen. So if the patient has cytokine release syndrome, the earlier you can intervene, the better, as Dr. Evans has already sort of laid out, because you can sort of mitigate and stop it from escalating to a higher grade. But your team has to be aware of what to look out for. Normally, when a patient is on any sort of oncologic treatment and they come in with fever, you reflexively think it's infection and you give antibiotics and things like that, draw blood cultures. And you don't necessarily think cytokine release syndrome, where in this, you really need to think cytokine release syndrome. Even if you are working up for an infection, you really need to be putting those things in place to sort of mitigate cytokine release syndrome. So that is one thing. And also having, certain medications on formulary like tocilizumab, which can be difficult because it's cost prohibitive, to be honest. And so every hospital system doesn't want to keep this on formula, especially if you're not using it. So, these are really the things that need to be in place. Most centers that have sort of incorporated bispecifics have a designated champion, somebody to play quarterback to organize the rest of the team. So we have plans in place when patients come in. We have a contact information, and anything goes awry, they're there to fix and sort of get everybody realigned. So when the next patient comes in, it doesn't happen. Now, the timings piece depends on what you receive. IV medications tend to have an early onset of cytokine release syndrome with bispecific versus a subcutaneous. And so with these subcutaneous formulations, sometimes these things happen at home, which patient education becomes very important. If you have a fever, make sure you have a thermometer at home. Some people actually have blood pressure cuffs. These are things you want to do to monitor. And then some people have advocated for other things to sort of help. Maybe make sure you have antipyretics at home, like Tylenol, ibuprofen. And some physicians are sending patients home with a pill in a pocket, which is steroids, which in some situations can mitigate cytokine release syndrome, or at least keep things stable till you can get to the hospital.
So thank you, Dr. Phillips. I know, Dr. Evans, you had already mentioned, just in talking about CAR T, you'd already talked about the word cure or curative, but we need data. But there was the update, I think, right? The 5-year data for Zuma and Transcend, those 2 trials. So from the quick glance at that, anything more you want to add to this sort of general feeling about CAR T and its ability to be curative? I know you talked again about needing more time.
Yeah, no, it really is time though, Stephanie. I mean, it comes down to that, and it's at least in the pre-CAR era, it was this. And this is true, and we tell patients that now, that hopefully it doesn't come back. In the minority of cases where it does, it's most common the first 2 years, and then a little bit through years 3, 4, and 5. But it's really uncommon. It's never impossible, of course, after 5 years with chemotherapy. So our expectations is that those kinetics or that dynamic should be the same, because it is an aggressive cancer, and you would think, how can it live around for 5+ years? And so I really think, these numbers we're seeing at 5 years, because it's what we call a plateau in the curve, that it looks pretty darn flat once you're getting out to 3, 4, and especially 5 years. And I feel pretty confident we can use the word cure.
Dr. Evans, I think widely discussed in patient groups is the accessibility on that end to CAR T.
Yeah.
You both are at, major academic centers. You've got all the things, all the shiny tools and the latest. But for a lot of people who live in the community, this doesn't seem to be very feasible.
That's a major issue. And Dr. Phillips aptly alluded to this. And when you look at, depends which data set you look at, it's maybe even some cases of patients who should receive it, maybe only 20, 25% who are. Not that it'll ever be 100%, but it certainly should be more than 20. And anytime you have a treatment anchored around primarily academic medical centers, when we know 80% plus of cancer care happens at non-academic centers, community centers, there's going to be a problem, and a problem related to access. And so what are ways to circumvent that or go around that is, well, of course, can we carefully, strategically, we don't want to do anything haphazard with any treatment. Can we try with certain community centers in collaboration with academic centers, or maybe on their own, working with pharmaceutical companies or even foundations, be able to do it? You betcha. And at least in New Jersey, there are some really strong non-academic medical centers who are giving CAR T carefully. So it definitely can be done. I think that's one. Number 2 is just better knowledge and maybe almost like prophylactic treatments, whether it's steroids or tocilizumab. There was some data on this at the ASH meeting. And number 3 is, as we said this early on, is second, third generation, if we're going to get those CAR T-cell therapies, where they're just engineered in a way where that rapid overexpansion of T cells, which is really driving a lot of the side effects, is more predictable or just doesn't happen. So I'm hopeful that we'll get there. But that's part of the reason why bispecific antibodies have become a little easier. And oh, by the way, I didn't even mention the whole, assuming you have access, it doesn't mean there's some patients who can you just generate, who can't wait 4 weeks, 5 weeks. They don't have enough time to wait for that to happen. And so so yes, it is a big issue, but it's really top of mind, and we're thinking about all of these issues, how to remedy. Do you guys have community centers, don't you, Tycel? Not just in Duarte, right?
We have a lot of community sites. They're not doing CAR though.
They're not. Are you guys? You know what we're starting to do, Tycel? I don't know if you guys we're kind of like segmenting it. Well, what we did is we loosened it to like almost like day right around a little less than 30. But what we're doing is we're at least having them do the pheresis now. we have New York Blood Center. It's like they can't do it through our fact, but they're starting to Faris. And yeah, it's going to be tough with current commercial CAR, maybe in a bigger community, but it's going to be tough in a small one.
Let me ask a different question here, and then we'll move on to follicular, I promise. But for bispecifics versus CAR T, I think a question I've also seen is, well, with it being more accessible, bispecifics, both in the community and in terms of wait time, it's supposed to be more off the shelf, right? We've heard that described a lot of times. When wouldn't you want to give bispecifics versus the CAR T? If a patient's asking and they have they have both as an option.
I mean, we said a little bit about it. We not sure they're as effective as CAR in that second line setting. But let's say, to your point, let's just say it's impossible for one reason or another. You can't get CAR. I don't know what you think, Tycel. It wouldn't be wrong to give bispecifics. The only mild note of caution would be it's not like rituximab. It's not like a cold antibody. And even though most patients do really well, you have to have some structure and organization in place, as we were talking about before you even give the bispecific antibodies. I think they're more doable for community oncology for sure than CAR T, but there still just needs to be that note of caution.
Yeah, I mean, thankfully, we know it doesn't appear that the bispecifics, at least with limited use, impact efficacy of CAR. I mean, I think we've had several data sets that show that you can still successfully harvest and then administer CAR T in patients who've been exposed to bispecifics. I think that was a big concern that everyone had, but so far, a French study and even a U.S. study doesn't seem like that is much of an issue in that patient population. But I mean, I think accessibility of bispecifics, because they're off the shelf, is there. And I think as these drugs move into other disease settings, such as solid tumors, I think you'll likely see wider adoption of the bispecific antibodies and more sort of incentive for community sites to do them, because again, they won't just be doing them for the limited number of lymphoma patients, but across the board, if they're giving it for lung cancer, if they're giving it for breast cancer, prostate cancer. I mean, there's far more patients in that sense. And so financially, it's more of a reason for them to, have structure in place for bispecifics and also the medication you need in case things go wrong.
And Stephanie, by the way, there's going to be or not going to be, there are two in clinical trials, at least two products of off-the-shelf CAR T-cell therapy, so-called allo CARs on that. So it really is about, I mean, the driving force is, yes, the current agents we have FDA approved are good, but to your point, there's still barriers, and we need it to transcend more of throughout the community for our cancer treatment.
Thank you. I appreciate the insights from both of you. For clarification, Dr. Phillips, what you're saying is there was some concern about bispecifics impacting the efficacy of CAR T given after, but that hasn't proved to be, because you guys are talking about bridging, I think, as well, right? The concept of, so what I'm hearing is it is looking promising in terms of the optionality that is here at the fingertips right now and in research. Is that right?
Yeah, I mean, I think, at this point, especially for the patients that sort of Dr. Evans has talked about, the one that maybe can't get to CAR T for whatever reason, at least we know we can maybe stabilize the disease enough to allow them an opportunity to get to CAR if it's feasible. And some patients, they just won't be able to get to CAR T because, again, you do need a lot more as far as social support than you do for other treatments. So that all has to be in place.
Great. Okay, thank you so much. Now shifting over to follicular and trying to summarize this as best as possible. Very different, obviously. This is a slow-growing, indolent disease. So let's start with the relapse refractory follicular lymphoma patient population first. Maybe we can set the stage going over what's available right now, kind of the go-to, and start there, and then go into maybe some of the updates. And we can start with Dr. Phillips here.
So right now in the relapse refractory phase, I think most people will use R-squared based on the Augment study, which did show a significant improvement over rituximab in this patient population. I think a lot of us are very comfortable with use of that medication, and the efficacy and tolerability seems to justify it in the second line space. After that, it gets a little bit more variable. I mean, you have bispecific antibodies approved, so there's mosunetuzumab and epcoritamab. CAR T is available in follicular lymphoma. I'll bet a little bit of a different argument because, again, CAR T does not necessarily have that curative sort of label as it does in large cell lymphoma. So a lot more variability about what you use in that space. And again, recently we had zanubrutinib and obinutuzumab based on a Rosewood study, which is the first time a BTK inhibitor has actually really shown any benefit for follicular lymphoma. And then there's tazemetostat, which is an oral EZH2 inhibitor for patients with an EZH2 mutation or those who are deemed to be unfit for other agents, which are all approved in the relapsed refractory follicular lymphoma space.
Great, thank you. It was a great summary. Dr. Evans, going into, again, this ASH, this big meeting, there was a late-breaking abstract, which I think typically means like, oh, this seems promising, from the phase 3 InMind study, which looked at tafasitamab and lenalidomide and rituximab for the relapsed refractory situation. Can you provide highlights from this and why patients should care or pay attention?
Sure. Yeah, this was an important presentation and an abstract. Dr. Lori Sen from BC Cancer presented it, and it really was built off of the combination, the R squared, Revlimid, or the other name lenalidomide, which we've talked about, in combination with rituximab. That's how we get the R squared, which is commonly used in the second line setting. So it was a placebo-controlled study of that plus or minus tafasitamab, and which is already FDA approved for relapsed refractory diffuse large B cell. So it's kind of moving and looking at into its entree into follicular lymphoma. And it was relapsed refractory follicular lymphoma. You had to at least have received rituximab therapy. And so a lot were second line, some were beyond. And the long story short is it was very effective. In fact, if you look at, there's certain things we look at called hazard ratios and what percentage point. So if you look at it relatively speaking, there was a 57% improvement in progression-free survival. And that's pretty significant. If you want to look at it by absolute months, it was on the median about 12 months, a little bit less than 12 months benefit. So this is a presentation. It doesn't mean it's FDA approved, although pretty encouraging. And I would hope and expect in the near future it would be submitted and potentially an FDA-approved option for patients. Did you guys participate in that study? We didn't do.
No, I didn't even know it was even going. I mean, I was surprised when I saw it, and then even more surprised about the results.
Yeah, I've always been hit or miss with. I like Monjuvi. I mean, there's like no side effects, and sometimes it works. But obviously, it's a tougher patient population than diffuse large B-cell lymphoma. But yeah, it was very impressive efficacy, and I should have mentioned tolerability. Looked pretty tolerable. We've known that through the diffuse large B-cell approval that it's a pretty tolerable medication.
And I think one key point also is that the standard of care arm, they brought it up because I'm sure they thought they'd get criticism. It performed worse than the Augment study, but they enrolled patients with worse disease than Augment did. So it was a harder to treat patient population, and they still had very, very good results that look better than what we got on Augment. So hats off to them because they addressed the elephant in the room ahead of time and had data to support it.
They did, and Stephanie, just to be thorough, it's a single antibody. It's a CD19 antibody, is what that tafasitamab, or the trade name is Monjuvi.
So looking at that and comparing it to what is approved for relapse refractory FL, Dr. Evans, how would you explain to patients like, well, here's why, and again, one side's already approved. The other side we're talking about is promising data in research. But yeah, how would you sort of paint that landscape for patients?
Well, it was it's one that's like many clinical trials, it's more than encouraging. It was a phase 3 head-to-head study, not just a phase 2, and you're not sure of the comparison. So I think it's unfortunately a little bit of a waiting game. Now, sometimes what happens in the United States, that there's this panel called NCCN that will sometimes list it on its site before its FDA approval, although usually they like to see a peer-reviewed manuscript and FDA approval. So really, it just really emboldens the point of how important clinical trials are. All of non-Hodgkin's lymphoma and Hodgkin lymphoma, for that matter, there's so many new and exciting treatments, but obviously it has to be done with caution on a controlled clinical trial.
And we'd mentioned before, again, the bispecifics in this case, but we talked extensively about them in DLBCL. What are the what's the response been in follicular lymphoma and relapse refractory follicular lymphoma with bispecifics?
It's been good. I think the data has been very impressive. They have more longer follow-up with mosunetuzumab compared to epcoritamab, but that's obviously because it was approved sooner. Uh, but the data is effectively to the point where I would think most people would prefer a bispecific over CAR T in a very similar patient. Now, there are some caveats. Obviously, some patients have more aggressive disease, more concerning features, where you would probably go to CAR T in that space. But for the majority of patients with follicular lymphoma, because of the safety of these drugs and the lack of hospitalization, which is important, none of the ones approved in follicular lymphoma require a patient to be hospitalized for observation. And very low rates of CRS. Mostly the ones that we see are grade 1, very few grade 2. And again, high overall response rate, high complete response rate, and very impressive durability of response. And, pending how things appear when the patient does relapse, I mean, if they still express CD20, it does offer the opportunity to treat these patients with a bispecific, which is some of the stuff that future research is looking to determine whether we can still get very durable responses on second treatment, because there's been very small data sets so far about the retreatment aspect. But that's the opportunity that bispecifics can offer patients. Again, still in a community setting without having to, travel far from home.
That's great. Thank you, Dr. Phillips. Dr. Evans, anything to add?
Just that, and you kind of alluded to it, slow growing and indolent. With that said, sometimes these diseases, even follicular lymphoma or related other indolent lymphomas, can pick up a head of steam, cause symptoms. And that usually is whether it gets really large or at any time it causes symptoms. It's certainly a trigger to start treatment at that point, number one. But number two, what's so critical, yes, it's treatable. Yes, we know now through randomized trials, life is extended with many of these therapies. It's still, generally speaking, not curable. And and so we have to just, even though yes, we're going to keep doing clinical trials, we're going to keep shooting for that cure. That's just where, not that quality of life is not important in diffuse large B cell, but it's just, I would say, ultra important in follicular lymphoma. And many of these trials, hopefully most, if not all of them, have some embedded quality of life measures to make sure, yes, we want a treatment that's effective, but that patients can still maintain their life. Because over a 20, 30-year period, some patients with follicular lymphoma may go through 6, 7, 8 different treatments. And our hope is during that length of life that a good chunk of it is off treatment, is treatment free on that. And that's why so many of these studies, thankfully, are being done with what's called time limited treatment, meaning not indefinite, nonstop treatment, that there's some defined period. Yes, you treat whether 6 months or a year or even 18 months, and then a pause, and hopefully can enjoy that remission off treatment for as long as possible.
That's a great point that you segued into. Dr. Phillips, I don't know if you have anything you want to add to that too.
No, I think he summarized the dilemma in follicular. You're less willing to take toxicity because, again, longevity and quality of life is paramount.
And just the one thing I'll add, Stephanie, is a lot of these treatments. We presented a poster at ASH. Dr. Vaishali Kenkri at the University of Wisconsin was the lead author. We have this Big Ten Cancer Consortium. We think of the Big Ten as sports and football. They are, but Tycel used to be at a Big Ten center in beautiful state of Michigan, Northwestern, Ohio State, Rutgers, Wisconsin, Indiana, etc., Michigan State. I don't want to leave any out. Penn State. I know I'm not naming all 10, but that's most of them. So we have a consortium where we're able to study. And so it was a study that Dr. Kenkri brought up is common treatments, bendamustine rituximab in the frontline setting. Usually it's for 6 months. And so one of the medications Dr. Phillips mentioned, tazemetostat, she brought it to the frontline setting and only gave 3 cycles of bendamustine rituximab. Very early, response rate 100% so far. But just to the point again, every trial in many ways is a good clinical trial. Hopefully we can shift many of these novel targeted even pills to the front line that are more tolerable, time limited, and garner these really long remissions without cytotoxic chemotherapy.
The Taz is actually, I guess, one of the more tolerable oral medications I've ever seen.
Really is, and it's remarkable. It's very early. I think it was only 12, 13 patients, in the part of but it's with it's a lead-in study, Tycel. So if you saw it, like you get the TAS and then you get concurrent TAS BR, and we're doing it agnostic of EZH2 mutation. And so, we'll have to see how that pans out, whether it matters or not in the frontline setting.
I think the big point you said is no added toxicity, which we saw with a lot of other drugs. Lenalidomide is toxic with Benda. Even BTK inhibitors can cause some problems with Benda.
That that's right, and it was investigator initiated, and thankfully we were able to convince the company not just to add it onto 6 of bendamustine rituximab, but let's add it, but let's actually try and do short course benda. So we'll see how that pans out. All of these, almost all of the medications that Dr. Tyson so well laid out, almost all of them in some form or fashion, in a good way, are being looked at in clinical trials in the frontline setting. And that's what we want to get to, is just super targeted, effective, incredibly well tolerated, yet time limited therapy for follicular lymphoma and other indolent lymphomas.
Yeah, it's really nice to hear that people are considering the follicular, the nature of it is over like time, a longer time period. And so how can we lessen the impact to the quality of life, the ability to live well day to day? Wrapping this as the last question is really an overall picture. We've talked a lot about the research that's happening, also about what's already out there. So thank you. What would you say to the patients, their care partners watching this, in terms of the landscape over the next few years, both in DLBCL and then in follicular, just sort of what are the trends and what are you excited by for patients and care partners? And maybe we can start with Dr. Phillips and then Dr. Evans, you can bring us home.
Yeah, I mean, I think in large cell lymphoma, I think we hit it on earlier. We are moving towards more personalized care, and then obviously, even though we're adding extra medications, it doesn't necessarily mean we're adding extra toxicity, which, in essence, hopefully gives more efficacy without impacting quality of life, or even adding long-term sort of side effects to the patient profile. So it's all good news for the patients because, again, everything for the most part is a specifically targeted treatment and not necessarily as generalizedly causing a lot of side effects. So I'm excited to see where frontline large cell lymphoma goes. And then even in the relapse refractory space, as Dr. Evans alluded to, there are more and more treatments coming along here just so that we are incrementally increasing the number of patients we're curing from this cancer. And, obviously less and less patients in the relapse refractory space and actually less patients that we're actually losing to this cancer, which is important and a big leap from where we were just, say, 5 years ago, where you could routinely say that about 35% of patients would probably have very bad outcomes and it was not much more we can do about it. In follicular lymphoma, I think at this point it's become quasi like what we see with Hodgkin's, without the ability to cure, but we're trying to improve what we're doing for patients with a very, high sort of recognition of tolerability. So any of the things that are moving up and sort of being added are basically drugs that are safe and are effective. But again, we've all talked about, safety is paramount. So that quality of life that patients deserve and sort of the extended sort of survival will actually be time that you can enjoy with your families without worried about side effects that come from these treatments. So I think that's the most important thing. I mean, we've already talked about tafasitamab and lenalidomide and rituximab. We'll have the bispecifics. Tazemetostat is being explored with R squared, and then eventually some of these things may actually move into the frontline space, and we can re-challenge the role of where chemotherapy fits in our patient population, even with time-limited therapies without cytotoxic drugs. So again, a very exciting time as we move forward. Maybe more confusing for us as physicians because we'll have more options, but that usually always, equals good outcomes for patients.
Dr. Tycel did an amazing job of giving a summary, and so I'm just going to put a pin in a word he said several times: exciting. That's what it is. It's an exciting time for investigators like Dr. Phillips and myself, but also, Stephanie, for you and patients and caregivers. There are a multitude of novel targeted treatment options. We talked a lot about immunotherapy, but also even some oral targeted therapy that are on our shelves now as we speak, and literally probably 100 plus new ones coming down the pipeline. And so what does that mean for patients? It hopefully means a lot of good things, a lot of more effective and tolerated therapy. But what I would say for patients and caregivers is always ask questions. Please never be hesitant to ask your oncologist a question about what are all of my treatment options, whether on the shelf or especially on a clinical trial. Never hesitate to bring up a side effect you have, whether it's numbness, tingling, or certainly a fever or something more significant. Just those open lines of communication are paramount. And lastly, there, of course, are family members, your doctor, but there's so many good societies and foundations out there that really can be a great anchor for patients to talk to other patients, get information, listen to certain videos like this one on hearing experts speak. So just a lot of great information, a fast moving field, but really in all great directions.
Thank you both so much for being here, for the work that you do, obviously going way above and beyond just treating your own patients. And so can't thank you enough, and we'll look to feature you again soon. Okay. And with that, we wrap another wonderful discussion here at The Patient Story. I just want to say I really appreciate these doctors who, again, take time out of their busy schedule to provide such great insights for us, and in a way that I think we can understand better. And we know that it is so important to be empowered and lean into this communication, have more conversations about things like what's impacting your quality of life, so that you, again, as patients and caregivers and partners, can work together with the medical teams to stay on treatments that are effective, or at least live life the way that you want to. Once again, we really want to hear from you, what we've done well, but more importantly, what we can do even better, what you're looking for with educational programs and patient stories. And that can be captured in a survey that's going to come on after this ends. So would love it if you could fill that out. Thank you again to our sponsors, Genmab and AbbVie, for their support of our independent patient program. And again, shout out to our partner, the LLS, the Leukemia and Lymphoma Society. Check out the links here on the side to the LLS's different parts of their website for their resources. There's the Information Resource Center, which provides free one-to-one support with questions across the board. And also their Clinical Trial Support Center, which is, again, free one-to-one support. You've got clinical trial nurses on the other end of the line trying to help you find trials, stay on trials, and answer all the questions in between. So thank you so much for coming. We hope that this was helpful for you as you walk away today. We hope to see you at another program soon. Thank you, and take good care.